Welcome to Chapter 11, Care of Patients with Immune and Lymphatic Disorders, including HIV and AIDS. Our theory objectives discuss key differences between primary and acquired immune deficiency disorders, summarize the ideal actions of therapeutic immunosuppressive drugs, illustrate the modes and transmissions for HIV, and discuss how pre-exposure prophylaxis reduces the risk of contracting HIV. List diagnostic tests for HIV and those used to monitor the immune status of HIV-positive patient, determine opportunistic infections, including viral, bacterial, fungal, and parasitic, that occur in HIV patients, give examples of autoimmune disorders or diseases within each of these three categories of autoimmune disorders. Compare and contrast the two types of lymphoma, including how they are diagnosed. Explain why the process of diagnosis and treatment for fibromyalgia would be difficult or frustrating for the patient. Construct how an allergic reaction occurs during an excessive immune response, and then relate the nurse's role in helping patients to control allergies. In terms of clinical practice, we want to make sure that during clinical rotation, you can review the facility's policy for exposure to blood or body fluids from an HIV-positive patient, list nursing measures for the prevention of infection for an immunocompromised patient, perform data collection on a patient in whom an immune suppressant disorder is suspected. Also, we want to be able to review a nursing care plan for a patient who has low immunity, write nursing interventions for a patient with fibromyalgia, and list the usual measures for treating an anaphylactic reaction, and locate the necessary emergency equipment on your clinical unit. In terms of immune function and dysfunction, immunocompetence means the body is able to set things in motion to protect itself. Immune deficiency would be the opposite of that, and autoimmune disorders are when the body attacks itself. Immune deficiency disorders, there are really two forms of them. Primary would be something that you inherit, and it's a genetic mutation. Some of the in primary ones are ALPS, CGD, CVID, and SCID, and can be seen further on page 217. In terms of acquired, human immunodeficiency syndrome, or HIV, and acquired immune deficiency syndrome, or AIDS, are our primary ones. There are diagnostic tests and treatment and diagnosis and planning in box 11-3 on page 218. HIV and AIDS. In HIV, there is HIV-1 and HIV-2. The pathophysiology has to do with the retrovirus and the reverse transcriptase putting genetic material on DNA of the host cell. There are three things to look at in your textbook regarding this: figure 11.1 on page 221, table 11.2 on page 222, and box 11.4 on page 222. Transmitting HIV, the three highest risks for becoming infected, including having unprotected sex, oral, vaginal, or anal, with an HIV-positive person, sharing needles and syringes with an HIV-infected person, and then maternal fetal exposure. Other possible risks are tattoos, body piercings, and blood products. Exposure prophylaxis. If it is pre-exposure, Truvada can be taken. Safe sexual practices need to be instituted. Blood products need to be scanned for anything that might be untoward. Vaccine development is in process, but not to the point of usefulness at this point. Box 11.5 on page 223 will further that information. Signs and symptoms. They might have no symptoms, or it might be flu-like symptoms. Sentinel infections are key there. Variable clinical presentations and latent periods without obvious symptoms are all common. To diagnose HIV, HIV-1 test system and OraQuick in-home HIV are two tests that can be done simply. Enzyme-linked immunosorbent assay, or ELISA, is another one, and then it always needs to be followed up with a Western blot HIV gene sequence test. You can see further on box 11.6 on page 229. Management, CD4 lymphocyte count will help give us information so that it can be managed with meds and different things. World Health Organization has a staging parameter, and then highly active antiretroviral therapy, or HAART, is very common. See Table 11.3 on page 225 and Table 11.4 on page 225 and 226. These are Kaposi sarcoma spots that you will see on the body. See further on figure 11.2 on page 227. Some cultural considerations to keep in mind. Factors that increase the incidence of HIV and progression to AIDS among minority groups are the lack of culturally sensitive and high-quality information about HIV risk and prevention. Socioeconomic status and limited access to health care also prevents people from taking adequate precautions. Health beliefs concerning sexual practices, roles of women, value of children in HIV treatment, and then the high cost of HAART. Here's our first audience response question. Which statements regarding human immunodeficiency virus transmission is or are true? Select all that apply. Number 1, breast milk can harbor the virus. B, 2, proper use of personal protective equipment reduces the risk of disease transmission. 3, needles exchange programs facilitate the spread of the virus. Or 4, needle stick injuries place health professionals at risk. The correct answers are 1, 2, and 4. Some opportunistic infections, viral infections, herpes simplex virus type 1 and type 2, varicella zoster virus, cytomegalovirus, hepatitis, and then bacterial infections including TB and Mycobacterium avium complex. Some others, fungal infections, there's a whole host of them, parasitic infections as well. Other complications include wasting syndrome, neoplasms including Kaposi sarcoma and lymphomas, and neurological complications. You can see figure 11.2 on page 227 for further information. Our second audience response question: in determining the optimal therapy for a patient infected with HIV, the physician considers which factors? Select all that apply. Clinical data, compliance with therapy, medication tolerance, insurance coverage, and physician's expectations. The correct answers are 1 and 3. For assessment data collection, we're looking at history and physical assessment, a focused assessment, and then a psychosocial history. Table 11.6 give sample nursing diagnoses as well. For the planning stage, we want to prevent secondary bacterial, viral, and fungal infections, prevent wasting caused by malnutrition, maintain or improve the present level of immune function, maintain adequate social functioning, maintain or improve current mental status. In the implementation phase, we want to make sure standard precautions are being followed, patient teaching is adequate regarding compromised immunity and infection control in the home, and wasting and syndrome and nutrition are addressed. In evaluating, data collection and analysis needs other health issues, HIV risk in the over 50 population, community education and care, HIV confidentiality and disclosure, and when a nurse is HIV positive, what happens, bloodborne pathogen exposure in healthcare workers, and then occupational exposure to HIV. Some autoimmune disorders, the local immune system is reacting against the body's own cells. It can happen locally, systemically, and mixed. Some signs and symptoms, there are more than 80 diseases thought to be triggered by an alteration in immune function. You can see table 11.7 on page 231. Diagnosis includes a health history, complete physical exam, and blood tests. Treatment and nursing management includes replacement or support of lost body function and therapies targeted to halt the destructive process. SLE, or systemic lupus erythematosus, autoimmune disease. The body produces abnormal antibodies that attack the target tissues instead of foreign agents. So there are discord, systemic, and drug-induced forms. SLE appears to occur after puberty and peaks between 15 and 40 years of age. SLE occurs more often in women than men. Etiology and pathophysiology: abnormal reaction against proteins found in the nucleus of body cells. Prolonged exposure to sunlight makes it worse, and exacerbation by drugs. All body systems can be affected, and weakness is a hallmark of SLE. You can see figure 11-3 on page 234 and figure 11-4 on page 234. No single test by itself confirms a diagnosis of SLE. You must have at least 4 of the 11 clinical presentations or lab test results. There is no cure. Treatment is targeted toward the symptom control and management to prevent exacerbations. Hydrochloroquine, an anti-malarial drug, aids in controlling SLE in the long term. Glucocorticoids, such as prednisone, are taken to reduce symptoms and experienced during major flare-ups. And then non-steroidal anti-inflammatory drugs are used to reduce inflammation and control pain. You can see the nursing care plan for more information on nursing management on 11.1 on page 235 to 236. Hodgkin's lymphoma, the etiology, pathophysiology, signs and symptoms, diagnosis, treatment, nursing management are all aimed at keeping the disease in remission, keeping it under control. A relapse would be the reappearance of the cancer or abnormal cells. Clinical manifestations and pathophysiology are on figure 11.5 on page 238. The figure 11.1 on the Evolve website has the staging of this. Non-Hodgkin lymphoma, etiology and pathophysiology, signs and symptoms, diagnosis, treatment, and nursing management are all key in keeping it at bay, in remission. Primary lymphedema is inherited form caused by a congenital condition in which there is a deficient growth of the lymphatic system, especially in a lower extremity. So chiefly affects females and most often becomes apparent during middle teens to early 20s. Secondary lymphedema is acquired form caused by an obstruction by trauma to the lymph vessels and nodes. Very often we see this with a mastectomy when the lymph nodes are removed, or extensive soft tissue injury and scar formation. Parasites that enter lymph channels and block them are also a way to get this. Patients may present with a variety of symptoms, including restricted range of motion, heavy feeling, aching discomfort, recurrent infections, and thick, hard skin. Regardless of the etiology, treatment goals are to minimize the impact of the disease process on the individual. Fibromyalgia, chronic systemic pain and multiple symptoms that are not caused by another source or disease. It affects women 10 times more than men and seen in women ranging from 25 to 60 years of age. Stressors such as infection, trauma, drugs, hormonal influences, and psychological distress can trigger fibromyalgia and its related symptoms. It is typically described as diffuse or multifocal pain with flare-ups and remissions along with migration from one area of the body to another. Although not a true form of arthritis, fibromyalgia interferes with a person's ability to perform activities of daily living and can cause significant fatigue and pain. Over the years, evidence-based research has supported the belief that this disease is caused more by an inappropriate neural response to pain rather than inflammation. It appears that this disorder may also occur because of a deficiency in the neurotransmitters dependent on serotonin and norepinephrine within the central nervous system. As fibromyalgia is better understood, more advances in the diagnosis and treatment of this disease with and without drugs are being developed. The most common feature of this disorder is musculoskeletal pain, hyperalgesia, heightened response to painful stimuli is noted, and then allodynia, painful response to non-painful stimuli. Here are tender points in fibromyalgia. You can see this in figure 11.6 on page 241. Some symptoms we see: tension or migraine headaches, jaw and facial tenderness, insomnia or waking up feeling just as tired as when the person went to sleep, vertigo, difficulty with concentration, memory recall, and performing simple mental tasks, anxiety and depression, numbness or tingling in the face, arms, hands, legs, or feet, sensation of swelling without actual swelling in the hands and feet, abdominal pain, bloating, nausea, and constipation alternating with diarrhea or irritable bowel syndrome, and then dysmenorrhea. Increase in urinary urgency or frequency or irritable bladder, sensitivity to one or more of the following: odors, noise, bright lights, medications, certain foods, and cold. Symptom relief, we use antidepressants, NSAIDs. Narcotic pain relievers are not as effective. Additional treatment includes exercise, massage therapy, guided imagery, dietary changes, and referral to a mental health provider. Nursing responsibilities, including getting a detailed assessment of symptoms, history, and documenting what the patient has already tried to alleviate them. Let's look at allergy for a bit. Allergy is an abnormal response to certain substances. It's considered systemic immune disorder rather than a localized one. The reaction can be seen or expressed in multiple body systems. Allergens can enter the body in several ways and can have either a local or systemic effect. The etiology, pathophysiology, signs, symptoms, and diagnosis, they often use a RAST test and also skin prick tests. There are drug allergies, food allergies, and treatment is to limit exposure to allergies and provide adequate control. Desensitization is also used. Hypersensitivity to reactions, better known as allergic reactions, are the body's excessive response to a normally harmless substance. The severity of the condition can range from a mild rash to life-threatening anaphylaxis. Type 2 hypersensitivity, delayed reaction allergies involving T cells. To get a diagnosis, a RAS test is done or skin test, scratch, and patch tests. Primary allergic conditions include anaphylaxis, which is the most serious, angioedema, asthma, atopic dermatitis or eczema, food allergy or intolerance, perennial allergic rhinitis or sinusitis, seasonal allergic rhinoconjunctivitis or hay fever, urticaria. 4 broad categories of allergens: contactants, ingestants, inhalants, and injectables. Collecting data, we want to look generally at the history of food intolerances, colic, abdominal cramping, bloating or pain, vomiting, and diarrhea in the absence of general illness. History of unusual reaction to any drug, insect sting, odor, or fumes. History of recurrent respiratory problems or seasonal flare-ups of any symptoms, and history of fatigue, wheezing, or shortness of breath on exertion. Skin, we might see itching, burning, dryness, scaling, irritations, inflammation, rash, and you want to note whether it's symmetrical and where it's located. Scratches and urticaria. Eyes, burning, itching, tearing, history of styes, redness, discoloration below eyes or allergic shiners, and conjunctivitis, rubbing or excessive blinking. In the nose, we're looking at history of nose twitching, stuffiness, recurring nosebleeds, sudden episodes of sneezing or snorting, allergic salute, pushing the nose upward and backward with the heel of the hand, nasal polyps, and nasal voice. Mouth and throat, we're looking at open mouth breathing, continual throat clearing, mouth wrinkling with facial grimaces, redness of throat, swollen lips or tongue. Ears, we're looking at history of hearing loss, drainage from ears, and then we're also looking at the neck for palpable and large lymph nodes. Nursing implications include assisting in the diagnosis of hypersensitivity, helping the patient identify the particular substance or substances that trigger the allergic response, assist the patient in devising ways to avoid or at least limit exposure to these allergens, relieve the symptoms of allergy. When we're looking at anaphylactic reaction and shock, we want to look at the IgE mediated immune responses. If the mast cells depend on IgE to be activated, they typically are triggered to produce only a localized allergic response. Examples of this are allergic conjunctivitis or allergy-induced asthma. Non-IgE allergen response, iodine-based dyes for select radiological studies often trigger them. Select narcotics such as morphine and vancomycin, especially if administered too rapidly. Signs and symptoms include urticaria, which is hives, angioedema, which is swelling beneath the skin, wheals, which are small areas of swelling that itch and burn, and they may appear without subsequent anaphylaxis. Here you see the diagram of effects of anaphylaxis on figure 11.8 on page 248. For treatment of anaphylaxis, we want to establish a patent airway, administer oxygen, administer intravenous epinephrine, administer antihistamine, institute measures to prevent or control shock, and then provide psychological support during the course of the syndrome and its treatment.